and thank you, Thaisa. Well, I've been a speech-language pathologist for 30 years, working with face trauma, temporomandibular joint dysfunction, and orthognathic surgery since 1997. I was able to observe the development of speech-language pathology rehabilitation through studies, clinical practice, and theoretical practical classes. The speech-language pathologist, I think it is almost here. Okay. The speech-language pathologist works to organize the neuromotor programming after the bones basis relocation, always aiming the functional according to each patient features. Therapeutic resources that assist clinical practice, a drainage of facial edema, cryotherapy, thermotherapy, laser therapy that I work, electrical stimulation, surface electromyography, all resources part of the professional speech-language pathologist practice. Okay. It's not working.
Alzira,
okay.
Click twice. Okay.
There are validated protocols to work with orofacial motricity, as well as to patients that underwent orthognathic surgery. There's a video too. In my practice, I adopted pre-surgery evaluation in order to project the functional of muscles, speech, breathing, chewing, and swallowing. I have continuous contact with the surgical teams, and therefore, I already know their way of functioning. Each team has a way of work, and I adapted to it. As I said before, previous evaluation is very important to know the patient before the bone discrepancy correction and to project by the specific features of each deformity, the functional purposes, dental situation, muscular, functional adaptations, possible pain, and or discomfort situation. For instance, example, tongue posture of class 2 patient is interdental, but the posterior portion is pretty high. Or the class 3 patient, on the other hand, also has an anterior tongue posture, but wide and hypotonic. The temporomandibular joint of the former class 2 patient may present joint pain. The relation between shape and function determines limitation, facilitation, and even therapeutic approach. There is not a unique protocol to all patients. Individuality will guide me to the better approach. Motor and functional development are adapted to skeletal shape, as you see there. For example, it is expected a kind of functional behavior from a patient with open bite, is anterior tongue. Class 2, lack of labial seal. Class 3 patient, hypotonic tongue and muscles asymmetry in bone asymmetry. This is a recent example of class 3 patient pre-surgical evaluation in which the expected adapted features to shape are wide tongue due to the intraoral space, excessive muscles contraction in order to keep labial seal. Some anatomic and functional features of class 2 patients. Another example of recent syndromic class 2 patient evaluation. The example of a class 2 patient with breathing difficulties due to anatomic deviation. Features: few intraoral space, frontal tongue that you see there inside, lack of labial seal and shortening of suprahyoid muscles, and also snoring and apnea due to the reduced pharynx space. Can you see that lateral image? For the mandible retroposition, here we have the most common way of mandible advance and maxilla retroposition class 2. The patient does not have a good quality of life. The reported symptoms and assessment of the patient show the functional imbalance related to bone structures that way. Breathing disturbance of a subject presenting mandible retroposition and is real, and depending of the maxilla-mandible relation, it may be severely impact breathing. Orthognathic surgery is possible in cases like this. After previous study, it is determined whether surgery is indicated. Maxilla-mandible disproportion is congenital, hereditary factors, and therefore is early childhood breathing, chewing and swallowing adaptation and are observed. Functional adaptations related to shape. There are cases in which mechanic interventions, braces, are capable to redirected facial growth and therefore avoid irreversible deviations. This is a surgical cases. Some features, for example, vertical and horizontal faces deviations, that one. Vertical and horizontal deviations. Dental arch and occlusion and adaptations. This in the legacy. Nasal angle, ocular nasal mouth asymmetry, like this one. High arched palate, it's anomalous palate, intranasal growth. Sleep disorders, like you see that. That is child growth and development compromised. With the hard tissues adaptations, it occurs adaptation of soft tissues and therefore in the stomatognatic and muscles functional. It is possible to observe narrow pharynx and as consequence, smaller airway, as you see there. With orthognathic surgery, the oropharynx air volume increased due to mandible anteriorization, usually related to maxilla manipulation too. Aesthetically, the chain is also mandibulated. These are some anatomic and functional deviations most found in patients class 2, which inferior intraoral space is smaller than superior space, anterior tongue, soft palate insufficiently. An evident posture deviation. This is a class 2, is a breathing deviation of posture. One of the indications for orthognathic surgery is snoring and apnea. Thus, decrease in respiratory space due to the posterior position of the mandible makes breathing difficult. This is a video that I make. Another symptom is the movement limitation of the oropharyngeal region. After mandibular advancement and sometimes maxillary, also the entire mandibular musculature is stretched and it increases the respiratory and oropharyngeal space, but it is necessary musculatory area. This patient is post-surgical class 2 and has already been discharged. I receive patients in the first week after surgery to start follow-up and to improve recovery and functional results. My job is to facilitate to reorganization to change neuromotor pattern, to reprogram to new muscles functional memory. To welcome and to listen patients' complaints who is impaired due to liquid feeding, edema, paresthesia, and usually repentant. I have to explain, to give solutions to complaints, to improve the patient's well-being. And also, I need to start the treatment with laser therapy preparatories to drainage and to promote sensitivity. And after, I start cryotherapy, cold stimulus, and also to minimize paresthesia. Most guidance were already given before surgery, but not all patients are addressed to this appointment. To sleep reclining at 90 degrees, increase of edema. Recipes and types of feeding is not that way, is not indicated. Muscles that are going to be stimulated. It's very important to understand that we are doing is awareness. That is paresthesia and how to stimulate the nerve. Right tongue posture, since the new bone relation allows the reorganization of this deviation. The patients arrive to my practice with edema, sensitive disturbance, and hematoma sometimes. Some surgeons use rubber bands without minimal mouth opening. It's hard to feed. Paresthesia, it works a protection system, but others inconveniences as edema and a mandibular movements restriction. This is the videos too that I use with patients. I use visual resources as a pictures, explanatory videos, patients, pictures, and videos. And I work with proprioception and awareness of a new functional pattern. Post-operative X-ray shows the position of the monocortical plates. It's important to see before my practice. This is an example of an indicative case of orthognathic surgery, but it is not possible due to all these comorbidities. This patient cannot be submitted to anesthesia. She has a lot of pain of her joints and muscles, snoring and apnea from the posterior mandibular position. I have to proceed in a palliative way through laser therapy, maneuvers, and massages. Edema. The patient reports a lot of discomfort. We started drainage of the first day of care, which causes immense relief and well-being. Drainage is a strong message to bring the existing fluid to the lymphoid glands. This is my practice. How I do the drainage with a strong message. Important to explain during the process, because the patients do in on their own place. 5 or 6 times a day is an evaluation. It's a diary evaluation. The paresthesia occurs due to traumatic nerve aggression caused by surgery. In fact, it is a protection system that minimizes the perception of pain. Although the patient does not like it, sensitivity returns. But I can stimulate sensitivity with laser therapy and later a cryotherapy. The results are very positive. The video 2. Oops. Here. Low intensity laser therapy. It is a gold standard feature. Thus, function is to complement speech therapy work. I work with massage maneuvers, and the laser is a complement our job. I use it in all sessions, nerve path for sensitive stimulation, as it causes the permeability of cell membrane under repair, and soon after the myotherapy as perceptual information. It's important to say the speech language pathology is more important than that laser therapy, but it's a complement job. Also laser therapy. A video. I show us how I work. After laser therapy, manual work through the drainage. Isotonic movements for greater oxygenation, perception of harmful habits. We entered with cryotherapy. This is cryotherapy. Cold stimulation in the paresthesia area and synesthetic stimuli. The teleconsultation, currently, it is the most adopted way of the patient is already in speech therapy. For newly operated patients, I attended in person. In these cases, it's not possible in a virtual way. The first attendance, the second one, the third is not common, but as in the whole world, we have to adapt it, and so speech therapy teleconsultation works. I explain everything that I done during the session, and the patient himself practice until complete learning, which makes a virtual care more effective. We have a technological resources like photos, videos, and material that the patient has. In my practice, I measure at the beginning and at the end of the session, record each technique used in therapy. The patient learns to measure and also record daily in your place. The video. Okay. The guidance not only about what type of food, but also the form of feeding, less time and quantity. I have to adapt to each surgical team and thereby personalize the speech therapy. There are teams that request immediate light mandibular movement, but the most common is to wait around 10 or 50 days later of surgery. I need to prepare the musculature before the more oxygenation and relaxation to observe possible muscular compensation during the mandibular movements, muscle pain, or mandibular joint pain. Once again, the musculature prepared start lightly with isotonic exercises during all the sessions. Is a preparatory muscles for the drainage or laser therapy is very important isotonic exercises. I would like to thank you the invitation and everyone's attention. Thank you.
Thank you, Alzira. Very good speech.
Thank you.
If you have any question, please contact her or write it on the chat. And I would like to introduce another beauty from our group, Rosiane.